without further ado, I'm going to hand over to Daniel, who's going to kick us off. Thank you very much.
Thanks, Rosie, and yeah, thanks for the opportunity to talk today. Geoff and I are going to do a bit of a double act. So I'm going to start off and give you just a bit of the background, some of the kind of foundational understandings, and a bit on language. But then it was actually 10 years because we had a 3-year pilot project that led into TRUUD. So I'm going to touch on that briefly. Then I'm going to give the overview of the TRUUD program and then hand over to Geoff, who's going to do a deeper dive into one of the main intervention areas, working with central government, and then also how we went about doing the program-wide evaluation. Um, so I'm going to share my screen, and I think it's that one. Um,
That's looking good, Daniel.
Great, and it's moving.
Yes.
Yeah, so thank you. The first thing we wanted to say was we actually spent about 6 months discussing what we mean by health um, around that time. Not full time. You'll be pleased to hear, but it was a really interesting discussion because this really was at the heart of what we were trying to do. Obviously, funded by well, the funder was particularly interested in non-communicable diseases and health inequalities. But actually, there was lots of discussions about broader interpretations of health, whether it's planetary health, whether it's focusing on inequality specifically, whether it's focusing on medical-based intervention, population-based, etc., mental health, physical health. So when we talk about health, and we'll use the term interchangeably, we're sort of encompassing kind of everything, which from my point of view, I tend to talk about planetary health because that sort of feeds into kind of everything. It's got equity in there, it's got health in there, it's got well-being, etc., etc. But basically, one of the learnings that we had on the TRUUD program was that it's absolutely okay to have plural understandings and to have different understandings as long as you know what other people mean by what they're saying and as long as they understand what you mean by what you're saying. So we actually ended up with this term and a bunch of other terms like upstream, transdisciplinary, etc., etc. We ended up with many, many different meanings of the same word, but with a much clearer understanding of where everyone else is coming from. So I just say that up front because obviously we're talking about health throughout this whole thing. So it just gives you hopefully a bit of understanding about where we're coming from. I'm not going to spend any time on this stuff because you'll all be familiar, but obviously the built environment links to health in a whole range of different areas. And one of the reasons why we're talking about planetary health is not just because of population health or individual health, but also wider environmental factors and how that links through to health as well. As it says here, cities and urban development are very significantly linked to planetary health and wider environmental factors. And I put this in because this is a development in South Germany, in a place called Freiburg. This is an urban extension for those urban planners out there. They might be familiar with this. Anyone who's not an urban planner, if you are aware of it, then I'm very impressed. It's a large urban development in, as I say, South Germany. It has around 15% car use, 80% walking and cycling. It's I've been to visit. It's as quiet as the countryside. It's got a very good tram system. It's incredible in many, many ways, but it's also not that replicable. About 90 odd percent of the population vote Green. So demographically, politically, it's not that representative. And it also came about over about 30, 40 years of a whole range of different things happening. One of the first things that happened back in the day, back in the 70s, was there was a proposal to build a nuclear power station, which brought together the kind of liberal urbanites with the more conservative rural folk, and united them against this application for a nuclear power facility. That then kicked off a whole sort of green lefty revolution. They also have different federalized structures in Germany, which gives the local authority much more control over infrastructure, etc., etc. So basically, what I'm saying is there's a very complex network of things that go into making healthy places. And this is a very rare example of where they've got a lot of it right, but it's not necessarily representative of a whole range of other areas. So I'm putting that there up front because that's kind of the benchmark from an urban planning point of view about what we're trying to create. Um, so yeah, that was sort of feeding into the background of this project, which was called Upstream, and it was funded by Wellcome back in 2015. It was a 3-year pilot. Um, and this is how we characterized the kind of challenge that we needed to try and address. So basically, on the bottom left, where it says human and planetary health outcomes, downstream, what this illustration is trying to show is that we know quite a lot about that bottom left-hand corner. And I'm speaking as a former urban designer, urban planner. I spent a lot of time talking to architects, engineers, and all those kinds of people. So yeah, for many, many decades, these what you might call technical disciplines have been trying to figure out how to design and in fact they really do know how to build good quality places. So it's not really a technical challenge in terms of how we build quality places. We know how to build quality places. The problem is who's in charge? Who are the clients? Who are the people that fund it? Who owns the assets? Who owns the land? And also who's making the policy? And so we wanted to look further upstream. And that's the other thing that this illustration does is one of the things that the funders wanted us to look at was upstream intervention. So going back to the point about health and the definition of health, the other word that we spent a long time talking about was what's the definition of upstream? And so this is very much a linear uh, process that we're showing here. And obviously these processes are highly complex. So we're aware that this is not a linear thing, but this is nonetheless useful because it also infers issues to do with power and agency and control, which was a very important part of what we were trying to understand. I'm not really going to go into the details of this, but basically the findings from about 30 odd interviews in the pilot project was that emphatically both the public and private sector recognized that health wasn't being integrated into urban planning. They were very supportive of this economic model, which we'll talk about in a second. And it was also highly complex. They identified loads of different potential barriers and opportunities across a range of different themes. But basically, this was just setting up the TRUUD project, which we'll come on to now, um, which is the main point of this discussion. So that was kind of the background in terms of the pilot. So in terms of the TRUUD project, I've already mentioned what the UK PRP, the UK Prevention Research Partnership, those are our funders. I don't actually know, Rosie, whether they're the same people that are funding you or not.
So we funded our earlier project called Act Early,
Yeah.
but Healthy Urban Places is our separate, but very similar in names. So
Okay. Brilliant. Thank you. Okay. So presumably everyone on this call is then quite familiar with the sort of funders and the aims. The one thing to say about this is, as Rosie, you just said, there were a range of different other consortia. Ours was focused particularly on property development and transport planning. Those were the two main areas. So the UK PRP has funded stuff on, uh, as Rosie's just said, on Act Early, childhood intervention, but also on food, alcohol, and tobacco, on violence, crime, green infrastructure. There's one on urban green infrastructure as well called Groundswell. So ours was one of two really that was focusing on the infrastructure, urban infrastructure, and the only one to be focusing on property development and transport planning. And what we wanted to try and do specifically was look at how we can integrate and value health at what we call the root cause decision making points. After speaking to our systems experts on our team, they pointed out that in complex systems, there's no such thing as a root cause. And so we've had to sort of slightly qualify that root cause discussion. But at the same point, I still think it's useful because it's again coming back to that point about power and agency. So anyway, that was our sort of stated aim. Lots of people involved. There are about 63 odd researchers over the course of the 6 years across 6 universities. But the main point about this slide is that so the money came predominantly from the health world. It went into a medical school, but then it went out into economics, engineering, law, spatial planning, real estate investment, etc., etc. So You don't need to read this in detail, but just if you look at just the bold headlines of each, this gives you a sort of summary of the first 3 years of the research. So we did a load of interviews, about 130 odd interviews. We did a load of workshops. The economic valuation I'll come back to in a minute because that was a piece of work that was started in the pilot, but then continued through TRUUD and is one of the main bits of the intervention, if you like. And towards the bottom left, where it says intervention identification, there was quite a substantial process to pull all that data together from the interviews, from the workshops, and basically look at that column two. So we identified a range of different problem areas that we wanted to then that were identified by the people that we were speaking to. So, for example, at national government level, it was, a lot of these will be very familiar to people, but it was good to have the evidence. Lack of integration across departments. At local government level, obviously, lack of resource. At private sector, it was about dominant delivery models, for example, the big volume house builders. Um, you get the impression. So there's basically a whole range of different problem areas that we identified. And then through that process, we long listed 50 areas of potential intervention. And then we shortlisted from that list 7 areas that we wanted to intervene on. And that was based on a number of reasons, but mainly where we felt we could have the most impact, but also the competencies or expertise of those on our team. Um, and so I'm just going to talk about those 7 areas. But before I do, I'm not going to go into the details of this, but there's a paper if you're interested that lists and goes through in much more detail those 50 different intervention areas and some of the main themes coming out of that. So the 7 areas that we ended up with are here. And I'm again just going to give you a quick overview, and then Geoff is going to go into a lot more detail in that top one on the left, the number one government valuation tools. So these were the 7 teams. We had a team with Geoff and others engaging with central government, particularly via MHCLG, the Ministry for Housing, Communities and Local Government, and on their particular valuation mechanisms. We had a team that was an integration of management and psychology between Bath and Bristol, or in fact, it turned into be Stirling and Bristol. And they were working with 2 large private sector companies called Oxford and Dandara. And they wanted to test a psychology-based intervention that would help prioritize health in their decision making. There was a team led by University of Reading on real estate investment, and they worked with 2 companies called Federated Hermes and Landsec. These are very large American and European real estate companies, and they were interested in how they could use the economic valuation tool and integrate it into their investment decision making, both on individual projects but also across whole portfolios. And that work it's pretty much tied up, but there's still a report still outstanding on the impact on their broader decision making. We can share lots of links to any of this if people are interested, because we've got an enormous website with loads of links. So if there are any particular areas that people are interested, maybe you could let us know and we could point you to those specific areas. Then there was a team from the Bristol Law School that ended up focusing on health impact assessment and the use of health impact assessment at local government level, particularly. And that was in response to local government officers not being confident about when and how and where they could apply health impact assessment within the law. And so there's loads of resources on HIA and the law. And then there were 2 on the ground case studies. We had 2 full-time researchers in residence. One was in Greater Manchester, or Transport for Greater Manchester, and one was in Bristol City Council. In Greater Manchester, they were looking at transport across the city region and integrating health and key performance indicators, KPIs, into their transport planning strategy. And in Bristol City Council, they were focusing on a large-scale development project called Frome Gateway and the spatial framework of that Frome Gateway, and integrating health into that and trying to improve the health within the planning of that large development. And then there was a final team looking at public involvement, because for those of you who are familiar with urban planning, there is a lot of consultation that happens in urban planning, but a lot of it is not very good. And sometimes, in fact, often that's not necessarily anyone's fault. It's just there are too many people to involve and it's very, very difficult to do it well. So what we wanted to try and do was to try and circumvent and overcome that problem by trialing new ways of trying to get what we called meaningful public involvement to communicate citizen voice. It's still an ongoing challenge, to be honest, but it is helping us to learn how we take that forward. And then finally, in the bottom right, you can see one called Research on Research. And I can talk about that more if you like, but it was more, sometimes we originally called it meta research and changed it to Research on Research. But it was basically, we went into this knowing that just operationalizing this whole program was going to be a challenge. So we wanted a team of people to be basically evaluating how we were doing things on an ongoing basis throughout the whole 6 year period. And we're still writing up some of those findings. So I just want to spend the last couple of slides focusing on this economic valuation tool because it's been such a core part of this main program as well as the pilot. So basically, it's just a big Excel spreadsheet, and it's based on a series of systematic reviews linking various different aspects of the built environment to health outcomes, and oh, that work was done by the University of West of England. They then passed over the quantifiable data from those systematic reviews to the economists, and the economists then looked at the links between those health outcomes and then three areas of cost. And I'll come back to that in a minute because I think I've got another slide on those three areas of cost. But basically, the main highlights here are it's based on 8,000 medical studies, 14,000 valuation studies, and 450 primary studies. But we've ended up with a model which has around 200 causal pathways. And to give you one example of that causal pathway, it links traffic noise to hypertension, hypertension to child conduct disorder, and then child conduct disorder to the cost of medically treating that child conduct disorder. So that's one pathway out of 200. It's based on, it's what they call an input-output model. I'm not an economist. I studied economics for my undergrad, but stopped immediately after doing that. So we're very much reliant on this from the Bath economists. So if you have any technical questions, we might have to redirect you, but we'll do our best. So yeah, three inputs on the environment, the population, and the exposure, and then three outputs on morbidity, mortality, and monetization. And so these gives you an idea of the various different causal pathways. From in grey, it's showing you the various different outcomes, but then in the coloured ones in the middle are the various different aspects of the built environment. Apologies. So this is just to highlight those three areas of cost. In fact, it's split into four here, but you can see on the right-hand side, it says societal cost. So direct costs, as they're called, is the cost of medical treatment. Indirect is things like sickness, absence, and that kind of thing, but we also talk about lost productivity. Disutility is the sort of usually the biggest and the least possible to link to specific end payees. So wider pain and suffering, it's sometimes described as, and then it's got mortality there as well. And in terms of what it's able to do, and we're still in the process of developing this bit out, but depending on those areas of cost, you're then able to link it to specific end payees. So for example, if it's about cost of medical treatment, then typically it would be the NHS or social care. Productivity links to employers, national government, etc. So that's the sort of whirlwind tour. I'm going to hand over to Geoff. The only other thing I wanted to add was within that economic model, there's a range of evidence. So for example, we have loads of data on air pollution, but relatively quite limited amount of data on, say, overheating. So the art, if you like, of using that economic model in the best way is to have a really good understanding of that evidence base and then be really clear about how you're applying that model in practice. So yeah, that tees up Geoff, I think, quite nicely because that's what their team have been doing for the last 3 years in central government. So over to you, Geoff.
So yeah, thanks, Dan. Yeah, so I'm Geoff. I'm as Rose said, lecturer in public health policy at University of Bath, and I was on TRUUD pretty much throughout. Missed the first couple of months, so anything that was wrong with it, I blame on what would happen before I started. I'm now part of the Local Health Global Profits project, which is another one of the PHI UK funded consortia based out of Bath, but collaborating with lots of others on commercial determinants of health. But I'm going to pick up, as sort of really where Dan left off by talking about in a bit of detail about one of the interventions on TRUUD. And then I'm going to bring that back out by looking at how we thought about looking at the impact of TRUUD as a whole, thinking about these different interventions. We're interested not just in each one of them, how they sort of impacted that specific space they were in, but how they might play out if they were all working together. So one, as Dan explained, we had these 7 interventions in TRUUD, and one of them focused on national government specifically. We had this overall aim of trying to integrate health evidence ideas into decision making in central government that sort of shapes urban development. So specifically looking at Ministry of Housing, Communities and Local Government, and the other teams in government that are looking sort of transport and housing related. This all came out of the analysis and research done in the first half of the project that Dan spoke about, all the interviews, systems analysis, workshops, and so on. And we did a lot of work trying to understand, well, how and why is or indeed isn't health more integrated into urban development decision making. And you can read some about some of that in some of our outputs, like this paper here. And we ended up focusing specifically on the work that's the appraisals done within the Ministry of Housing, Communities, Local Government. I don't know how familiar people are or aren't with appraisals. I've got the definition from the Green Book there that I'll let you read yourself rather than me do a sort of ham-fisted attempt to define it. But essentially, it's an important part of government policy making. It happens early on in the process. It's a way to understand the value for money and the impacts of how government spends its money. So in this case, of urban developments, projects and programs that are funded by government. And in MHCLG, we're looking at appraisals in 2 sorts of directions. So firstly, they carry out appraisal work as part of how they secure funding from Treasury for the sorts of programs, the urban development programs that they want to fund. So in spending reviews, they put forward proposals to Treasury for huge amounts of money. And at the other side of this, when they are deciding how to spend their money at the local level, what sorts of projects to fund, they also are carrying out appraisals to understand what the impact's going to be and do they represent value for money. And the sort of the problem that we were focusing on that came out of the first couple of years of the research was that health and wellbeing outcomes, they're not part of how MHCLG understand the value for money of urban development. So when they're making these decisions about what to fund, these aren't being influenced by health impacts. So whether a new project or different options that you might be funding, the extent that they are improving or putting health at risk isn't being taken into account, which obviously we feel is important that it is. And so that's what we were trying to address through this intervention. I'll come back to kind of a little bit briefly around what we did, but to skip towards the end in terms of the impact of this work. Well, the house model that Dan talked about is now being used after our work, is now being used by Ministry of Housing, Community, Local Government to understand health and well-being impacts of urban development projects. That's sort of the headline of that. So when they are making decisions about what gets funded, then they'll be using this model to put health outcomes into that picture. It doesn't mean that all decisions are being based on health specifically, but it's part of the decision-making process. It's being considered when they're understanding the impacts of what they fund. Health outcomes are now in that picture. And so this is being published within the what's called their MHCLG's appraisal guide, which sets out the methods, tools, and so on that can be used in governments to do appraisal of urban development. And it's also recommended for use at the local level as well. So through the appraisal guide, the house model will be promoted for use by local authorities and combined authorities when they're making decisions themselves, including when they're bidding for government funding. So part of our work has been exploring how to make this work as useful, impactful across the whole system. So not just within central government, but more widely as well. In terms of what we did, I don't intend to go into any of the sort of the detail, but we work sort of broke into these three phases. So initially doing a lot of work raising our profile in Whitehall, working out exactly where to take this, where there was appetite, lots of exploratory meetings and so on. The bulk of this was a kind of a really intense period of co-producing a version of the house model that was sort of fit for purpose for government appraisals. So thinking about how this could be applied alongside all the different tools that they have to use, developing a version that kind of meets government standards for evidence and rigor. So for example, removing some of those pathways that Dan mentioned in the model that don't have a strong evidence base behind them. Developing case studies and examples of applying this model to governments, MHCLG's needs, working with lots of different departments to make sure this kind of meets their standards and it's going to be signed off, because getting this into the government sort of systems takes a lot of discussion, lots of work with different departments, different teams. And we're now at a point really where we're in this final phase. I think never-ending series of sort of peer review and comments and feedback and tweaking of outputs, but we've got a version of House now that is fit for use in MHCLG that's available for anyone to pick up. It's got accompanying sort of methods, guides, and case study examples and things like that that's alongside it. One of those slides with lots of text on that I don't expect you to be able to take in, but it's really to flag that, yes, we work very closely with our key partners within MHCLG and Homes England, but we also engage with an awful lot of other stakeholders as part of this process. We worked out, we had about, I think, 140 meetings with different government teams and departments over a couple of years. So obviously quite an intense process, but also lots of seminars, sort of conferences, meetings with stakeholders in sort of private sector, local level as well. The idea behind this is trying to come up with something at the end that is going to have impact and is going to be used over time. We didn't want to just be another tool, piece of guidance that's kind of available that no one's able to use. So this is exploring that kind of wider implementation and thinking how to make this land in the system it's going into. And happily for us, our government partners were really keen on that as well. And it's important for them that, yes, it's being used within MHCLG, but also being used at the local level. And where we're at now, well, the model is already being used in the early appraisal work over the New Towns programme, which is great for us, potentially sort of really big impact there, putting health and wellbeing impacts into decisions about where those new towns might be and what they might look like. So that's positive. This updated appraisal guide, including House, is going to be launched. Well, it always keeps getting dragged back slightly. It was going to be early November, then late November and early December. But we're looking at a couple of weeks' time now, and we're confident that will happen. So at that point, this work's published and the model is then available for anyone to pick up and use. And our small team from within TRUUD is being funded to continue this work. We're funded by MHCLG to continue this work for another 18 months. So a lot of that is promoting it and sort of telling people about it, making sure it's being picked up and used, the model, in government and outside. And then starting to think about how can we make it better, strengthening those areas of weakness within the model, improving sort of functionality and usability and so on. So I could waffle about this for ages, but I'm going to stop and move on to the other part of this presentation, but happy to follow up. We've got lots of links on our website, as Dan mentioned. Because while that's one example of the sorts of impacts we were able to have through TRUUD, but we were really interested in thinking about how can we understand sort of the longer term and kind of broader impacts of the work that we've been doing. So Dan showed you a version of this. He's already talked through what the sort of different interventions within TRUUD were, but essentially all interventions that were trying to influence these different areas of decision making, trying to put health evidence and thinking, I suppose, into these different areas of decision making to cumulatively impact the quality of urban environments, and then somewhere down the line to improve health outcomes as well. And the reason we're thinking like this is that we know that changing any one of these areas is positive. It's likely to have benefits, but it's through intervening in multiple parts of this system that we are likely to have much more long-term impact. One of the challenges we had on the project was that, as Dan mentioned, lots of researchers working in different teams, different disciplines, everything moved at different pace. And what we found was that when we came to the point of trying to do this evaluation work, that 4 of these interventions were kind of developed to a point where we were able to sort of say they've been implemented. We were able to do some early evaluation on them. We were able to say a little bit around what their sort of short-term impacts were. So the other 3, they're no less important. It's just that they weren't developed at a point where we were able to do any of this kind of bigger picture evaluative work on them. But we were left with the central government intervention I've just talked about, the 2 that Dan spoke through at the local level, so focusing on legal capacity and on embedding health within sort of spatial planning within at Bristol. And then our work with the private sector, looking to shape sort of senior investor developer decision making in the sort of psychology-based intervention. And so we were then trying to think about, well, what we wanted to understand what the impacts of these interventions broadly were. These are some headlines, and these are short-term immediate impacts. And essentially what we were able to show through kind of very immediate evaluation work was that all 4 interventions had some positive impacts. So I don't need to sort of talk through the first one because I've talked about our central government work. But we're able to show then that through our law-based intervention had a positive use on confidence, I suppose, to use HIA at the local level. We're able to evidence some integration of health evidence and health thinking into local spatial frameworks in Bristol. And the psychology-based intervention had some, again, short-term impacts on intentions to do more on health, to think more about health amongst our private sector partners. Lots of caveats around all this. We know these are only sort of short-term impacts. Probably one of the challenges of evaluation in a program like this is that even though we had 5 years of funding, to get to the point where we were able to actually evaluate these was right at the end of that time span. We'd want to be able to follow up over future years to see if these impacts have lasted. What we really wanted to do was to, as I said, to look beyond these sort of short-term effects and think about their cumulative impacts. Our question was really, if we were to take these interventions, these 4 interventions, or indeed the 7, if they were all acting at on the same sort of development at the same time, how could this lead to healthier outcomes? And we decided to focus here on new large-scale developments, tying in with current policy initiatives around, obviously rapid home building, lots of focus on new large-scale developments. So really topical at the moment. We wanted to think about how this could play out and then explore that with stakeholders. So just to finish, I'll just talk you through that. This is a quite simplistic sort of mapping, I suppose, of the decision-making over a new local development. And so what we would want to see is that health is integrated into these different parts of the system. But what we know is happening is at the moment from our work is that there are gaps in how health is being included. And this is what we wanted to address through those 4 different interventions. So putting health evidence and thinking into these different areas of decision-making that cumulatively affect what urban development ultimately looks like. And we know that our baseline idea here is that health is not well integrated into new schemes currently. So what we were able to do is, of course, is then map on the impacts of our interventions onto this same sort of system, if you like. So taking that baseline and then building in the coloured text here, those short-term immediate impacts that I flagged on a couple of slides back. And what we were really interested in was saying, well, if this happens, so how could then, does this lead to this nice idea of a healthier new development? And obviously the answer is, well, it's really hard to say, and there's so many other factors that are at play here that we know this is a sort of a simplistic picture, but this is kind of a model, I suppose, that shows how this TRUUD intervention with these 4 different components targeting different parts of the system could play out. And we'll be happy to talk more about this, if you like, in a couple of minutes. But just to flag that we then, in the last 6 months of the programme, ran some stakeholder workshops exploring these impacts. We engaged with 45 cross-sector senior decision makers, at least one of whom is on this call, you can see. And we asked them really a series of questions about this evidence, this emerging evidence from the TRUUD programme. We're interested in thinking, okay, these are short-term immediate impacts that we can evidence now, but what seems most promising? How can we maximize the sustained impacts of these interventions? So we want these to last. How can we kind of encourage these interventions to be used and to have long-term impacts? And bring it all back to thinking about barriers and challenges and what else needs to happen next. We know that we won't have solved the problem through TRUUD of unhealthy urban development, lots of different avenues it could go forward in. We're happy to share these slides if that suits Rosie and Amy, and we've got some links in here that you can access the sorts of what came out of these workshops in detail, but just share some headline findings here. And again, I won't go into detail now. We can talk about them in the remaining time if people like. Again, maybe nothing hugely surprising in this, but there are a couple of interesting things which that people really felt that if you want engagement in these type of interventions, people to use these sorts of tools and evidence that we're providing, that they wanted evidence of their long-term impact, particularly thinking about, well, how can this actually improve health? It's a real challenge for us because we are trying to influence decision-making now in order to shape developments over the next few years, in order to then have health impacts over sort of the next 5, 10, 20 years after that. So there is this challenge around how can you create a convincing case for the impact this is going to have. A lot of discussion that if you really want these interventions to have impact, what you need is stronger regulation and people to actually essentially have to use health evidence and can think about health at different parts of the process. And there's probably some good discussion we can have around that if people are interested. I think I'll leave it there. So make sure we have a little bit of time. Dan mentioned our website. We've got, so it's the website here, lots of briefings, papers, podcasts, videos, etc. on there. So a good place to find out more if you're interested. But I shall be quiet and pass back to you, Rosie.
That is fantastic. Do you want to stop sharing, Geoff?
Yeah.
Brilliant. So thank you so much. And I just wanted to say what an amazing project that has been. And I'm absolutely gobsmacked by the impact that you've had. I think it's fantastic. And I'm really delighted that you've been able to come and give us an overview, because I think there's a lot that we can learn in the work that we're doing. And also we're coming up against a lot of the same challenges that you are as well. So I'm really keen for us to sort of develop a close working relationship as we move forward. Now, we have had some questions in the chat, and Daniel's been prolific. He's answered them all, which is fantastic. So I think we've still got some time for questions. So if there's any further questions, we can do these in person, online. So please pop your hand up. Or if you stick it in the chat, I'll come to you. There's a couple of reflections from me. So thank you, Amy, the instruction how to raise your hand, that I wondered if you could comment on. So some of these relate to some of the things that have been raised in the chat box so far. The first is about this idea of health impact assessment and how we can get this embedded into planning moving forward. And we know that there is so much variability in how these are done. And I wonder whether there's also variability in how much people really are invested in them. And I wondered if you had any reflections about, who's responsible for doing those health impact assessments? Is it local authorities, is it developers? What do we need to do to make those as effective as possible? So that's my first sort of query for you guys.
Geoff, can I jump in on that one? This is an area that I was very heavily involved in for about well, a number of years before getting involved in Upstream and TRUUD. And I was coming out of basically, I did my training in UE on urban design with a team. For those who work in urban planning, Hugh Barton and Marcus Grant, who developed the health map, for anyone's familiar with it, and developed their own process of assessing the quality of urban environments, which they call the spectrum approach to sustainability appraisal, which I don't think is around anymore. But lots of people adopted this health map into their way of looking at the urban environment and the wider urban environment. The reason I'm mentioning that is because this feeds into health impact assessment. Impact assessment is used globally to assess a whole range of different projects. Quite often, it's used on massive mining schemes or huge major infrastructure projects. And so there's a big overlap between HIA and EIA and SEA. And I don't know how familiar you all are with all those different assessment mechanisms within the planning world. The main thing to note, though, is that environmental impact assessment is aimed at projects and it's legal requirement. SEA or SA is aimed at plans and programs, and it's also a legal requirement, or was until Brexit at least. And after Brexit, it was adopted into UK law, but it's currently in a process through the latest Levelling Up Act to try and get rid of that and move on to a new system called environmental outcomes reporting. Although they can be used interchangeably, and if there are any experts on this, you're probably more up to date than I am nowadays. But HIA is not mandated, apart from in Wales, as someone pointed out. This has just changed recently, which is fantastic. We actually had an event in Bristol Law School recently where we debated this. We've just written a chapter with Ben Cave, who's putting a book together, the Handbook on Health Impact Assessment, which is coming out next year. And he wanted a chapter on the UK and urban development, which myself, Michael Chang, and Ed Curtin-Darling have contributed to. But in short, it is a bit complicated for those who don't work in this area. So one of the links I shared in the chat is to some work done by the Bristol Law School, where they worked with through the local government association with lots of different local authority officers to try and understand which local authorities require health impact assessment and when do they require health impact assessment. And so what they found was there's a massive variation across the country. There's different triggers, as in the size of the development or various other triggers, etc. And so we end up with this sort of quite varied landscape in terms of who's doing it, the quality of what it is, whether it's comprehensive or rapid, yada, yada, yada. However, what we ended up discussing, and this is the final point, is that there are pros and cons to it being either mandated or not mandated. Because quite often what happens with, say, environmental impact assessment or sustainability appraisal, you're basically at the lowest common denominator. Once it's made legally a legal requirement, then you basically do the bare minimum, arguably, and it becomes very technocratic. Whereas with health impact assessment, there's a massive wide range. You get some really good ones. You also get lots of very, very poor ones. In terms of who's doing it, it's both public and private. It just depends on the situation. Largely, it's probably private because they have the resource. The public sector struggle to find the resource. But if you've got a local government with teeth who require it and they're really on it and they've got resource to back up what they're doing, which is quite rare, then they might get a good outcome from it. Sorry, that was a very convoluted answer.
Thank you. I mean, it's incredibly complex. Just as I have the floor, here's privilege here. I think like my reflection, which I think is the same as where you guys are at, is that there's a lot of appetite and willingness to think about health, certainly from local authority level, also from government level now, I think. But there seems to be, to me, a bit of a leaky bucket from how you get to that to actually the development of the master plans and what's coming down to that hard level profit with the developers. And I'm interested in understanding what you think are sort of the key levers that we've got for the developers to make sure that it's not a tokenistic approach, and that they, fundamentally what we're asking them is to do things in a different way that's likely to be more expensive, and they're not going to see the benefit of that return on investment potentially.
Geoff, do you want to go first on that, or shall I jump in? I've obviously got stuff to say as ever, but
No, I'll let you do it, Dan. I just want, as a quick point, I think that um I'd be interested to know what you think, Dan. I don't know if it has to be more expensive. I think there's something around making the clear case that actually lots of these things don't always have to cost more. And that's maybe something. I'll pass over to you, Dan.
yeah. So I think the point about the expense is definitely a real one, but there's a time aspect to that. So, for example, when people talk about urban development from a private sector point of view, they quite often split it between what people refer to as speculative or trading-based development, and this is particularly landed at the volume house builders, where they build a house, sell it, move on. Whereas the argument that it's better to have investors like pension funds and big investors over the long term is that they're not just wanting to just build and move on. They have a financial interest over a longer period. And so it's that whole idea of what is where does your profit come from? Just from that one example is one example of how it depends on the business model. The other point is, as a society as a whole, and this links into obviously democracy and short-term political cycles and all the rest of it. If the return is coming out within the next business cycle or the next political cycle, then obviously that's going to be prioritized politically. Whereas if we're talking about long-term, which we are, prevention, this is a 30-year plus challenge, whatever, how many years you want to put to it. So yes, it is more expensive potentially in the short term, but in the long term. And so it's how do you overcome those challenges, which in and of itself is an enormous challenge and it's not easy to fix. By the way, the other point I'd make, going back to your point about HIA, and one of the conversations we're having with Bristol Law School and other HIA experts is where you apply HIA, because a lot of HIA is applied very downstream after most of the decisions are made. So actually, one of the things that we've been really trying to sort of push on is why isn't health impact assessment applied much earlier on?
Mm-hmm.
Because if you can change it sort of at that sort of national level through use of HIA, because it can be applied anywhere, it's very adaptive. So if you can identify which sort of policy pieces at the national level might then be filtering down, that's where HIA might have the most impact, arguably.
Yeah. Okay, brilliant. Thank you. We've got another couple of minutes if there are any burning questions from our attendees. It's a great offer. Thank you. We will make your slides available, Daniel and Geoff, and also Amy, if we can pull out all the really useful links that the team have put on the chat as well, that would be great. Okay, well, I think then it is my honour to thank you so much for an amazing seminar today. We've really appreciated hearing from this fantastic project, and I hope that we will be able to keep in touch and work with each other moving forward. I wanted to thank everybody for coming and for logging on. Hope you found this a really useful overview and enjoyed hearing about the project as much as I did. We will now be taking a little winter break for our seminar series, so we will be back in early spring. Our next seminar is on the 25th of February, and we have Matt Hobbs from Sheffield Hallam University, who's a spatial data scientist, coming to talk to us about his work. So we will, as usual, put all of our details on our LinkedIn page and website. And thank you very much. Enjoy the rest of your day. And thank you again to Daniel and Geoff. Take care.